This is Dr. AYYAPPAN V NAIR. I'm consultant shoulder specialist at Manipal Hospitals, Whitefield, and I run the fellowship program of shoulder surgery at Manipal Hospitals, Whitefield. So I'll be speaking on the AC joint. So the AC joint is a very complex joint. It's got two main ligaments. That the CC and the AC ligaments. Both are very, very important in the stability. So in the AC is basically the capsule, which got an anterior, posterior, superior, inferior capsule, and the CC is basically made of the conoid and the trapezoid. So um, we have had published papers on the acute AC joint fixation, the chronic AC joint fixation, and also in the hook plate fixation of the AC joint. So next questions we have to answer when we are treating an AC joint is, do we operate in all cases? And what happens if we don't operate? What is the ideal time to operate, and what is the ideal technique? So if you look at the treatment algorithm, so the concepts are quite clear. In type 1 and type 2, you need not operate. Conservative management is definitely good. And type 4 to type 6, you definitely have to operate because these are very complex injuries with quite a bit stripping of the fascia. And type 3 injuries, it's always, there's no proper data saying that we have to or we don't have to. So we'll be delving into this now. So the controversy is always on the type 3. The type 3, normally you say it is type 3 when the CC distance increases by 25 to 100%. And there's a definite disruption of the AC as well as the CC ligaments. So there's definitely lack of evidence for type 3 injuries. And the proper surgical indication for a type 3 are a failure of non-operative management. And primary surgical treatment we can definitely do it in throwing athletes and manual laborers. In athletes, there's no proper evidence and the data is not clear if we have to operate or we don't have to operate. When we look at the non-operative outcomes of type 3 treatment, so successful clinical outcomes are definitely found with conservative management, that is without surgery in 80 to 96% of cases. When you compare the operative and non-operative, we find that data is almost the same. There's no difference in the data between operative and non-operative management in a type 3 injuries. So that means if you look at the data, it says that 88% versus 87%, 85 versus 100%, and 88 versus 85.5 are the outcomes. That is overall outcomes when you talk about the type 3 injuries. When we look at the non-operative data, so what happened to these patients if you don't operate on a type 1 and a type 2? What happened over a period of time? For 10.2 years, in 10 years time, you will definitely have AC joint symptoms like arthritis, pain, especially with overhead actions. Some kind of scapular dyskinesia can definitely develop in type 1 and type 2 over 10 years. What about the type 3s? So it's noticed that these patients would definitely have residual instability. 17% patient had weak power in the bench presses, and residual arthritis was found in 37% patients. Deformity was found in 96% patients. So next, coming to the concept of type 3B. So when you do a cross arm adduction shoulder AP X-ray, and if there is a overlap of the clavicle and acromion, as you see in the picture on the left side, so that is called as a type 3B. They are basically unstable fractures which can cause scapular dyskinesia and are definitely advised surgery. Timing of surgery, the older literature talks about of an acute, that is, if you want to do an internal bracing, that should be done within 3 weeks. But newer literature says that if you should try to do it as early as possible, less than 2 weeks. And it is always better to do an internal bracing with a graft augmentation. So that's a concept now. So that is, again, it is a better idea than just do internal brace and completely depend upon the internal brace, and we are not aware of, we're not sure about how much of healing happens in the CC. So early stabilization is always better. And when you talk about acute injuries, what are the techniques we have? What are the methods we have? So we have different fixations. K-wires do not be done because of the K-wire migration. And look at the Bosworth screws, they have its own set of complications. So we don't do it. The hook plate, again, I don't do it in my practice because it definitely shows that when we look at it biomechanically, there is definitely a movement restriction with the hook plate, and also there is definite erosion on the undersurface of the acromio. The hook plate again we don't do. And the ideal fixation would be a loop suspensory fixation, and it could be anatomical or non-anatomical. So we loop suspensory means there definitely could be a tightrope and a button, cortical button. It could be just a loop around the coracoid and the clavicle. So any kind of loops fixation can be done. So if you compare anatomical versus non-anatomical, anatomical is always better. So what is anatomical? So this is anatomical where you basically do an internal brace at the base of the coracoid and pass a tape and pass it to the clavicle and fix it on both ends. This is a single tunnel fixation, and you can see on the right side is a double tunnel fixation where there are two holes in the clavicle. So which is better? The right side, the double tunnel is always better. In double tunnel fixation, the problem is there could be clavicle fractures, and you should always think about a medial tunnel placement can be a significant factor for early failures. So coming to our paper which we published, and this paper is very important because we have tried to take care and negate all the possible complications which can happen during a fixation. So here we don't believe in using a jig which connects from the clavicle to the coracoid. So we drill the holes separately, and this surgery is done arthroscopically, and only the AC joint has to be opened up so that we transfix the AC joint and the CC. So here in this particular technique, we internal brace the CC and the AC ligaments. The another problem that normally people face is when you're drilling the coracoid, and there could be a cutout, because if you just look at it radiologically, we don't know exactly where to put it in the center. So here when you do it arthroscopically, you can definitely find the center of the base of the coracoid, and a single proper tunnel can be drilled. Chance of cutoff is very less. Then we're using a loop around the coracoid, so because of which the contact pressure is distributed all around the coracoid process, and we use a cinch suture so it holds up properly and there's no movement at all. We also described the usage of a Hohmann retractor under the acromion to hold the reduction in place. That's also very important. You can see the position, that's a B chair position, and you can see in the picture on the right, that is a B showing a separate drilling of the coracoid and the clavicle. A drill bit passed from from the up to down of the coracoid, and you can see now the tapes being passed and the Hohmann retractor holding in place, and you can see the transfixation, the figure of 8 fixation. From the dock button you can see that here the sutures are passed around the acromion, and you put a figure of 8. So this is how the final reduction looks like, and you can watch this video. So this video basically is the arthroscopic positioning. You can see the undersurface of the coracoid, the P minor being released. You can see the P minor being released, and then you can see that we have used a Arthrex sleeve which comes along with the jig. We have put in the center of the coracoid, we have drilled it 2 mm, and once it is drilled, okay, we pass a spine needle and a PDS through, and PDS shuttles a tape inside. You can see the tape coming inside. You can see the loop going up. Then you pull back so that the loop comes properly on top of the coracoid process. Now you widen the loop and pass one of the sutures, and sometimes you pass 2 sutures through the loop. And you can see the cinch switch has already been applied, and you're going to put half hitches and knot it up now. So now that's your half hitches and knotting up. So you can put 2 or 3 so that it holds in place, and then you have drilled the clavicle from posterior to anterior and pass a needle, the spine needle with the PDS, and then you shuttle the 2 ends of the suture tape through it, and you can see the Hohmann holding the reduction in place. Reduction in place, and you can see the figure of 8 suture. That means I've drilled the acromio from anterior to posterior and passed the remaining ends of the tape through it, and from the connecting the dog button to the AC joint. So that's the technique. So it's a very useful technique. It takes care of the reduction maneuver, holding the reduction, fixing the both the AC and the CC. There's no cutout of the coracoid, even distribution of pressure around the coracoid process. So all that's been taken care. Um, so ideally, when you talk about the AC joint, type 3 and above has to be fixed. And there's an ideal fixation, and you should try to operate within 2 weeks.